Welcome to DC2B Revolution, helping chiropractic students think big in order to live large. I'm your host, Noah Volz, and today I'm here with Dr. Gregg Friedman. He's a second-generation chiropractor and has been in practice for more than 30 years. Father and him, they have more than 90 years of chiropractic experience. That's a lot of years. In addition to practicing part-time, Gregg performs independent medical examinations, reviews records, testifies as an expert witness, and teaches documentation seminars to chiropractors all over the country. So, Dr. Friedman, thanks so much for being here.
Thank you for having me, Noah.
Yeah, my pleasure. And I wanted to talk a little bit about documentation because that's where I initially came into contact with you. I'm a student, you know, I'm starting to go into clinic. We have these SOAP forms that I fill out, subjective, objective, assessment plan. I'm just wondering what your feeling is on the way that students are currently doing documentation and the way that schools are currently teaching documentation.
Well, that's a great question, Noah, but I don't know that I can really answer it because I'm not sure how students are actually documenting now, and I'm not even sure how the schools are teaching it. All I'll tell you is that I've had a few students at my seminars recently and a few very new graduates from different schools, and they say that some of the stuff that I talk about sounds somewhat familiar, but some of the other things are like, wow, I've never heard that before. So the problem is this. When I was in school 30 plus years ago, we learned how to do SOAP notes. But back in those days, to be honest with you, no one really cared about how we documented. Literally, no one ever looked at it. Nobody ever asked for our records. We just would, you know, make notes and subjective. The patient felt better or not better. And then objective findings were they had some subluxation somewhere. And assessment, they seemed to be doing okay. Plan, I adjusted them or did whatever else I'm going to do. And that was kind of it. It wasn't until we started getting asked for records on a regular basis, which started happening somewhere around 20 years ago or so, where we were like, wait, you want our what? You want to look at my records? And the funny thing was, I remember the first time I got this request on a personal injury patient, I called the adjuster and I said, what do you want? And she said, we want your records. And I said, oh, okay, but I mean, I wrote them and everything, and I don't know that I could read my writing. How are you supposed to? She goes, that's okay, send them anyway. And I said, well, what are you looking for in these records of mine that you probably won't be able to read? And she said, we're looking to see if you establish medical necessity. Now, I remember pretty clearly about 20-something years ago when those words were first uttered, and the whole profession back then went, what? We had no idea. We never even heard of the term medical necessity. We didn't know what it meant. So I asked her, I said, well, what is that exactly? And she said, well, I don't know. And I said, but if you don't know what it is, how are you going to know if I did it or not? And she said, well, I'll know it when I see it. And I thought, ruh-roh, I don't see this going well. And I thought, you know, I better figure this out because if this keeps happening, we're in a big pickle. So I had to start figuring out what to do with it. So I don't know how students are learning right now how to document. Maybe you're learning all the right things. Maybe you're missing a few things or maybe not. I don't know how they have you documenting in clinic, but all I can tell you is in practice, I would estimate that 99.9% of all chiropractic records that I review are not just lacking, but grossly lacking. In fact, if anybody were to look at their records, whether it was a Medicare audit or a me audit, or personal injury review, they'll lose. I mean, it's that bad. It's very difficult. So we have to get in there, and that's why I'm glad I'm speaking in Kansas City in a couple of weeks, and I'll be talking to some students there as well. And I need to get into those schools and say, look, this is what we have to do, and what teaching you in school is a great start, but we need to go into a few other things. For example, we learned about problem-oriented medical record. Maybe you've learned about that. We've learned about ODG guidelines, CCGPP guidelines, all these other, you know, HCFA, Medicare, all these different things. And we've got to figure out a way to document this stuff, but not just for an insurance patient, not just for a Medicare patient, not just for a personal injury. We've got to find one way that we can make work for literally every kind of patient, regardless of who's paying, and it's just the right doctor thing to do. And that way, no matter who looks at it, everyone will know what we're doing. And this is a big thing for us, because this, in my mind, is really the most effective way that we can communicate to the public what chiropractic is doing, what it is that we do. And right now, we're doing a horrible job at it. If we can improve this one thing, Noah, I think we can really make a difference.
Yeah, I completely agree with you. And that's why I'm so glad that you decided to, come on the show and kind of share your expertise and share what you're seeing in the field, and share, some of the ways that we can improve this, without teaching your entire documentation seminar in the next 10 minutes that we have together. You went through quickly, like some of the, the problem-oriented medical record and some of the things. As a student, where can I get more information? Where can I figure out how to start to integrate some of this documentation language into my current documentation in school?
Well, some good sources for you would be, let's see, CCGPP. So that's the Clinical Compass Guidelines or Practice Parameters for Chiropractors. They're excellent. It's a great start for us. It's kind of like an algorithm. So I think that you can find that at ccgpp.org, I believe. And then there's ODG, or Official Disability Guidelines. Those are not really chiropractic. Those are evidence-based for all providers: chiropractors, medical doctors, physical therapists, massage therapists, acupuncture, all of it. They've got a whole bunch of research on that. And once you're out in practice, you'll start realizing that more and more payers are using these official disability guidelines to cut chiropractic with that. So I think it's at least good to know kind of what they're talking about. The problem with them is that it's a subscription-based thing, which costs a few $100s a year to subscribe to. I've got a few 1-hour webinars through chirocredit.com, though, where I've taken both the combination of the ODG and the CCGPP, and I put together like a program. One of them is called Clinical Justification of the Chiropractic Treatment of, I've got headaches, neck pain, lower back pain, shoulder pain, stuff like that. So that gives you an idea. CCGPP, like I said, is really good. The Medicare guidelines, Medicare has requirements for chiropractors. Now, it only applies to Medicare patients, but once you see these requirements, it's really pretty good, and it's quite easy to do. And it's something that we can do as chiropractors very, very quickly. And that's one of the big problems that chiropractors have. They say, Greg, if we have to do all of this documentation, there's no way that I can see more than 4 patients in an hour. I'm like, well, that's ridiculous. And I understand if that were the case, then none of us would do it. We would just take our chances. But there is a way to do this. You've just got to be able to know all the different nuances here and be able, for example, I was on somebody else's webinar recently who was teaching about Medicare documentation. And this doctor knows a lot of stuff about Medicare documentation. But when I was looking to see what he was recommending, I thought to myself, well, that's okay, but that's really not required, because if you do this, that isn't required. So why don't we save ourselves a little time and just do the required part? We could even do more than what's required in very little time. Also, there's tricks about, one of the big weaknesses I see, Noah, is in the patient history. Learn that history. But like part of the problem-oriented medical record, right? What I was taught in school, tell me if you were taught anything different so far. What I was taught in school 30 plus years ago is patient comes in with, you document their chief complaint. Well, that's easy if they come in with lower back pain or neck pain or headaches. That's their chief complaint. But in the real world, most patients come into us with headaches, neck pain, and lower back pain. So you're like, okay, well, we were told in school 30 plus years ago, okay, of those 3 symptoms, which would you consider the chief complaint? And the patient would say, the lower back pain is worse. And we would say, okay, and that's what we would document. Oh, we'd still treat the rest of it, but we'd only document the lower back pain. And it wasn't until I learned about this problem-oriented medical record, I thought, oh my gosh, I had no idea. It never occurred to me. Could you imagine treating the patient for these other problems and not documenting that, and some bad outcome happens and you've got to defend yourself now? Or someone like me has to defend you and it wasn't documented? Could you imagine that? I thought, so here's a first little gem for you. When your patient has multiple symptoms for which they want treatment, you consider all of them to be chief complaints, and you're going to document the crap out of each one of those. And by that, I mean you're going to do a full-on history for each of them. For everyone other than Western states doctors, they learn a little bit differently, but the acronym we use is OPQRST. Western states has a few different letters, but the same concept in there. You're going to find out OPQRST, and I mean all those letters. Do not drop off any of those letters. All those letters for each complaint. But there are faster, easier ways to do this than to sit there for 20 minutes per complaint, listening to the patient's story, because especially the older patients, they go into tangents. They want to tell you what color shirt they were wearing that day, what the weather was like at the moment that they hurt their back, and good luck trying to get them to stop, by the way. They just want to talk about that.
Yeah, I'm curious about this because I feel like a lot of that could be done in the written history, right? I mean, that's documentation. They're writing it in there. You're looking over it. You're making any notes if they forgot to fill anything in. I know in our clinic, we are required to do each complaint, and we're required to do much more than LMNOPQRST for each complaint, which means that most of our initial visits, if it's more than one complaint, takes at least 3 hours. I mean, there's just, you're new, you haven't done all the orthos, you know, right. It's difficult for the patients in that scenario. I'm wondering, you know, what you would recommend for somebody like me in the school that I'm at.
Yeah, that's exactly it. Years ago, I found the same thing, and I said, I just don't have time to sit there. I mean, if it takes me 20 minutes to get through that with a patient for one condition, that's an hour for 3 different conditions. There's no way I want to do that. So I redesigned my intake forms just like that. So I made sure I had all the requirements from the OPQ for the problem-oriented medical record, and then I put on there the whole OPQRST for each symptom, and I made it be specific as I need them to be with that, and they do that. And then we would actually send the patient the paperwork ahead of time. When they would call into the office to make their appointment, we would get their email address, or we would send them to a website, and we would tell them, make sure you finish it ahead of your first appointment. Bring in the completed forms with you to your first visit. It will save you a lot of time. And now, in actuality, it doesn't really save them any time. They're just splitting it up into 5 minutes here and there. Who is it saving time? It's saving us time. So when they come in, now we tell them, we warn them, if you can't do it, something happens, your printer breaks, you run out of ink, that's okay. Just show up 45 minutes earlier than your appointment to fill out the paperwork. That is a gentle way of telling them, this is going to take you some time in the office, so don't think you're going to be leaving here after 10 minutes. So most patients, once you explain that to them, at least for my patients, they will do it ahead of time. They'll do at least most of it thoroughly. They'll skip some spots, and that's okay. We anticipate that. I'll have my staff greet the new patient, and they will ask them, did you get the paperwork? And the patient has in the paperwork, and the CA looks through every page. And if they skipped anything, which they usually will, the CA thanks them for doing what they did and gives it back to them and said, we just need to finish up these other things. It takes them maybe 5 minutes, and that's it. And then when the patient is taken into my room and I do the consultation, now we know that this has all been completed. So all I'm going to do is I'm going to read all of this back to them, reviewing it with them. Now, I'm literally going to read it back to them, and that's what's going to drive me to ask other questions. So the patient has done 99% of the work for me. I'm going to pick up the other 1%. For example, they might say for one symptom they have headaches. I'm going to ask them, show me what part of your head. Is it the front of the head, the back of the head, the side? What is it? And then I'm going to write in that specific thing. They may say neck pain, and I'm going to ask them, is it your whole neck? Is it one side of the neck, or what? And I'm going to write that in. And then there might be other things through the history that they're going to say, and I'm going to think, well, that's interesting. Tell me more about that one. But those other things are, let's call that the gravy. The basic meat and potatoes, they could do that for us ahead of time on paper. It saves a ton of time.
Yeah, I love this. And I'm we're talking about paper forms here, but it does seem like there's kind of a move within the industry right now to get everything electronic, and you even kind of what you were talking about earlier of just like standardizing the language that we're using for our documentation, so that, as chiropractors, we're communicating a similar language to DOs and MDs and PTs and Absolutely. Whoever else it may be. What do you feel like is what movement is being made in the direction of standardization, and how are the electronic health records systems supporting that?
Okay, so the standardization of terminology has been very frustrating for a long, long time. You have some chiropractors that live and die by the word subluxation. You have other chiropractors who say that we should get rid of that word altogether. Well, which is it? So we've got to come up with some kind of a plan on being consistent with that. I know that when I document the word subluxation in my notes, I always, and I mean 100% of the time, I always use the word hypomobile in front of that. Because if you ever use the word subluxation with a medical doctor, they don't recognize our subluxation. They only recognize the medical definition of a subluxation. So they look at us like we're nuts. Why would you manipulate a hypermobile, partially dislocated segment, where that's the opposite of what we're doing? But it's just terminology. So I will, if I'm going to use the word subluxation, I'll always use the word hypomobile in front of it. Just that one thing I think could get us far. Other doctors don't even like to use the word, and that's okay, because Medicare actually tells us other words that are okay to use. Fixation, restriction, aberration, whatever. It doesn't matter with that. It's segmental somatic dysfunction. You know, what's interesting, Noah, is even with Medicare, this is how messed up it could be sometimes. Medicare says that they only pay chiropractors. They only cover the adjustment when we're adjusting subluxations. However, they won't let us use the word subluxation into diagnosis. The diagnoses we use say segmental somatic dysfunction, because the subluxation diagnoses, those are the medical subluxations. So even with that, it's a problem. One of the things I really harp on with doctors at my seminars is the use of language. So like in school, we learned about, well, let me back up a second. When I like to ask people at my seminars, I want you to hold up your right index finger, or mirror me, hold up your whatever index finger. And then I said, I want you to put your finger on your right leg. Okay, go ahead, put your finger on your right leg. Okay, so now put your hand down. When I do that in a live audience, half the people are wrong. And this is why. Because we learn in school something called anatomical position. Have you learned that yet?
Mm-hmm.
Okay, so they learn it in medical school, they learn it in nursing school, they learn it in all the different healthcare schools, right? And it's a language so that regardless of our specialty, we can communicate with other providers in other specialties, and we all know what each other's talking about. So the problem is, most chiropractors will document this. They will say, patient has lower back pain that radiates to the right leg. Well, because I review records and I am in that zone of anatomical position. Let me back up. Anatomical position, we learned superior, inferior, medial, lateral, anterior, posterior, right? Well, in the language of anatomical position, the lower extremity is divided in half by the knee. And we refer to the extremity above the knee as what? That's the thigh. And below the knee is leg.
The leg.
In the upper extremity, divided in half by the elbow, above the elbow is the arm, below the elbow is the forearm. Well, when I review records, chiropractors are notorious for saying lower back pain radiates to the right leg. Well, I'm thinking, okay, you're telling me that it skips the thigh altogether, goes below the knee, which is possible, but you're also telling me that it encompasses the entire extremity below the knee, anterior, posterior, medial, lateral, and that's just not what's happening. So here's how we should be documenting so that we all know what we're talking about. I'm only going to use a few extra syllables. The lower back pain radiates to the right posterolateral thigh, and to the right posterolateral leg, and to the fifth digit of the right foot. You know exactly what I'm talking about. You could put your finger on it, you could trace it. You've already started thinking about your differential diagnoses. You started thinking about what orthopedic tests are you going to do that will probably be worthless. You're thinking about, do I want to do x-rays? Maybe an MRI? Should I send them somewhere else? So there's all these other things because I dared use a few extra syllables. And that's how we've got to document so that anybody looking at this stuff will know exactly what we're doing. Another pet peeve of mine are muscle tests. So we learned how to do muscle testing. I don't mean applied kinesiology. That's a whole different animal. I mean grading muscle strength, 5, 4, 3, 2, 1, and 0. And I reviewed a case one time, and a person was a passenger in a car. They didn't hit anything. There's no real accident. They simply went over a curb. The car went over a curb, and the patient felt neck pain. There was no documentation anywhere of any radicular symptomatology. Okay, so it was all actual pain only. However, the chiropractor examining this patient did a bunch of muscle tests and noted grade 2 muscle weakness in 5 or 6 different muscle groups. And I'm looking at that and I'm thinking, grade 2? Grade 2, that patient is sitting in a hospital room in a halo brace, waiting for the neurosurgeon to come in and talk about surgery that's coming up in 10 minutes. There's no way that makes us look like idiots. That makes that doctor look like an idiot, and it's a stain on the entire profession. And it's just because we're not thinking about this stuff. We learned this. I know you're learning this, or you've already learned it, and we've got to be legitimate about this. When we document the right terminology, that helps go a long way.
Yeah, completely. I think that's so important, especially for people in my position, you know, students where we're inundated with so much information, and filtering through all that information and figuring out what's actually useful and relevant and necessary for us to be successful in practice, and what's just information to pass our boards, you know, to get the certificate to actually, you know, start to be a chiropractor. It's really challenging to know, you know, what is actually useful and going to be relevant long term for all of us.
Let me address one more thing. You asked about the electronic medical records, the health records. So one thing to consider is that there's 2 different things, and a lot of people are mixing these up, and it's frustrating. There's electronic health record, that's one thing, and there's electronic medical record. That's another thing. They're totally different. And I maintain that electronic health record is a complete and utter waste of time for most, not all, but most chiropractors. If you're working in a multidisciplinary clinic, it might make sense. But for a chiropractic office or assistant chiropractor, if you're going to do it, don't spend any money on it. Electronic medical record, that's different. That's just a digital version of your SOAP notes, the chart notes. That is more accessible. It may make more sense, but here's the other problem. Again, because I review a lot of chiropractic records, and I would say when I review records now, which are mainly personal injury records, some workers' comp, and some malpractice stuff, 90% of the records that I'm reviewing these days are computerized. So you would think that helps, right? It's not.
Yeah, you would hope so, right? I mean, they've got all the templates in there, and they've got all the, you know,
all that's
things
all that's happening.
Fill it in.
Here's what I'd like to say. When your records were illegible and I couldn't read them, I suspected that they were crap. But now that I could actually read them, I could prove it. And that's what's happening. So what we're seeing in these electronic medical records, EMR, EHRs, all this stuff, I'm seeing the doctor's crappy documentation that they used to do on paper or a travel card. Now all it is the same junk in a nice legible format. That does nothing. In fact, that makes it worse. Now it's that much easier for us to look at that and say, that's ridiculous. So we've got to document. So if you could get an EMR or EHR, whatever you're going to use, you've got to make sure that it's documenting the right things at the right time in the right way and be legible. Not just be legible. So I just beg these doctors. I get requests all the time. Hey, recommend. So what do you want to recommend? I'm like, look, here's what I recommend. Learn how to document properly first before you go out buying stuff. Learn how to document first, and then you could evaluate these various programs and know if it's going to do what you need it to do or not. And then the other problem is some of these programs are designed around one methodology that is just not the case anymore. For example, these days, one of the biggest issues now is function. You've got to be able to assess function. And a lot of chiropractors, especially old timers like me, you know, we were taught it was all on your orthopedic neurologic test. And that is just not the case. Unless you're doing a lot of ridiculous stuff or disc stuff, that exam isn't going to show you a whole lot. And a lot of these programs out there are fully based on that, which is not going to help you out. You've got to have the ability to document function. The other problem is it's taking so long. So these doctors, they try these various programs and like, oh gosh, I could do this faster by hand. Yeah, maybe, but you're still documenting the wrong stuff. So it's got to be 3 things. It's got to be legible. It's got to be the right stuff that you're documenting, and you've got to document things at the right time. And for example, when do you do a re-exam, and what should that re-exam look like? I mean, that's a big question that people have.
Yeah, completely. And so, of course, the same thing came to my mind, like, well, is there an EMR system out there that's actually useful? And of course you answered that. You said you got to learn the documentation first before you find an EMR solution that is actually going to work for you, so you can make sure that it does work. So you don't recommend any EMR software. You recommend getting the documentation training initially. Is that correct?
Well, I recommend, I think it's better for doctors to learn how to document first. I do recommend one. It's one that I made, but I'm not going to talk about it here.
Fair enougch.
I don't want to. I'm not here to sell anything. So if somebody wants it, they can find me and ask me. But the biggest thing is if you don't know how to document properly. I've heard this from doctors. Doctors said, "I think I document pretty well." Just by you saying that, "I think I document pretty well," tells me that you don't. Because I would say, I know I document well. I know exactly how to document properly. If you're not sure about it, you've got to learn this stuff, because then you could look at these things and say, oh, okay, that's not going to work. That's going to make sense. It's so much easier that way. That what happens now is a doctor that maybe doesn't know how to document very well goes to a website for some product that's being sold, and they sign up, they click on for a demo, an online demo. Somebody contacts them and they schedule a demonstration. And the salesperson is demonstrating all these different things, and there's pretty colors, and there's little noises every now and then, and there's all these things. And the doctor, who means well, is thinking, wow, that's so cool. Those are such pretty colors. And that's really awesome to be able to document that. What you don't realize is that when I'm looking at these programs, I'm thinking this, that's not true, or that's completely irrelevant, or that's ridiculous. Nobody needs to do that, or that's a complete waste of time. You need to understand what's happening so that you can evaluate these things the same way. Otherwise, you are just so vulnerable to any sales pitch that's out there. And then you do it, and then you're miserable with it, and then you end up getting rid of it, and you just wasted thousands of dollars. That's frustrating.
Yeah, that's extremely frustrating. And that's why I'm so glad you came on the show to kind of give students a lens into documentation so that they don't make that huge mistake. You, as I mentioned in your short intro, you've been in practice for 30 years. You've seen the chiropractic profession change over that time. I'm sure, even, having a family member who is a chiropractor as well, you've seen a lot of changes. If you were to map out the trajectory of where we're going, what do you see kind of in the future of chiropractic, and what can students do today to be prepared for that eventual future?
Well, I'm hoping that this has not come up in school. I haven't heard about it, but there's been not a debate, not an argument, but a schism for decades in our profession, the straights against the mixers kind of a thing, which is just the stupidest thing I think I've ever heard like that. Here's a quick story for you. I was at a very fancy dinner in Seattle, Washington years ago, and we're all in our suits, and we're sitting at the nice restaurant. There's a table and there's wine, and I'm sitting next to a guy who's an MD and PhD at the University of Washington School of Medicine. All right, so this guy's big time, a really nice guy, and he's very professorial, very serious. And as we're drinking some wine, he says to me, "Greg, may I ask you an awkward question?" I said, "Of course." And he goes, "Well, I just don't know how to ask it, though. It's just kind of awkward." I'm like, "That's okay. Just don't worry about filter. Just let it out, and I'll answer it." So he said, "Okay." So he said, "My question is there, and I could see him struggling with this." I said, just say it. It's okay. Just say it. He said, "Is there really an organized faction?" And I'm thinking, okay. He said, of homosexual chiropractors? And I said, what? He said, "Is there an organized faction of homosexual chiropractors?" And I said, "Not that I know of." "Why would you ask that?" He goes, "Because I've only heard about the straights and the mixers." And I thought, oh, dear God. So I looked at him, I spit out wine through my nose, and I said, "Are you telling me that for all this time you've thought that a straight chiropractor was heterosexual, and a mix. Oh my gosh, are you kidding me? And he's like, is that not the guy? I'm like, we're so stupid. We are like the dumbest profession out there. That look, the reality is this: straight versus mixer is so stupid, because a straight chiropractor, they say only adjust, only adjust. A mixer might use modalities. I don't care what you do. I don't care. Look, the bottom line is this: are you getting good outcomes with your patient? That's all I care. As a reviewer, that's all I'm looking for. I don't care how you do it. As long as what you're doing is within our scope, you're not hurting the patient, and it's legal, I'm only looking at, are you showing positive outcomes? Are you treating it properly? So that's a really good thing. You've got to be able to show outcomes. Forget all this other stuff. You hear about the TORs and the tick and the progressives. And I mean, there's all, you know what? I straddle, I've been a chiropractor for so long, and with my family history, you know, I understand that. I've seen patients over the years who come into me with non-musculoskeletal stuff. They want to know if I could help. And I tell them up front, look, I don't have any research on that says I can do it, but I said, I will tell you this, in over 30 years of practice, I've worked on those a few times, and I've had some pretty decent success. Not every time, but you know, sometimes. That's fair. I said, I'm not going to hook you into, you know, 58 visit program for $3,000 though. Those kind of treatment plans, which I still see out there in our profession, kills us. That makes the entire profession look bad. And that's a big problem with that. But I remember when that started. I remember why it happened. It happened years ago from practice consultants, management consultants, because chiropractors have notoriously been weak at getting new patients. Most, not all, but they're weak at getting new patients. So these consultants said, if you're not good at getting new patients, we need to find a way for you to hold on to the ones that you have. And it made sense at the time. And a lot of doctors did these long-term treatment plans, and I did it too for a long time. I was very, very good at it. But then I stopped doing it because those patients don't refer as well. I found that most patients like to come in the first 2 weeks, or when you're going to get 80% of your referrals, the first 2 weeks. Why do you think that is, Noah? What happens in the first 2 weeks of care?
Well, hopefully the person starts getting better and gets improved outcomes, and that's why they refer.
The symptoms get better first typically. The function takes longer than the symptoms. They refer most people when their symptoms feel better. That's when you get them in those 2 weeks. So treatment plans. There was something on some of these Facebook groups that I'm in that these students were telling me about, that they didn't learn how to do treatment plan. That one clinician told them to do a 1 or 2 visit treatment plan. I'm like, what? 1 or 2 visits? That's like the 1 or 2 visit miracle cure, which does happen sometimes, but we can't predict that. That's not a treatment plan. Alternatively, a treatment plan is also not 58 visits or $8,000. That's not a treatment plan. There are very defined things that we've got to look for that are based on both symptoms and function. And there's a very defined period of time where, okay, we're going to do an initial baseline assessment. Then we're going to treat you for a trial of X period of time. And then we will reassess these functions to see if we're on the right track or not. And if we are on the right track, okay, let's go for another trial of this long. And if it's still showing improvement, keep going. If it's not showing improvement, is there something that you could change, a different technique, a modality, or a rehab, whatever that you're going to do? Change it, document the change, go for another trial of that period of time, and go on with that. So even for those chiropractors who love to see, you know, wellness patients, and they like to see, I have those also. I'm just very careful with them. I tell them, like, for that could take some time with that, and I don't know if it's going to happen or not for you. But I'm not going to hook them into a long treatment plan. We're going to go a few weeks at a time or so and do that. And in that period of time, I'm going to teach them about chiropractic as much as I can. And a lot of people will on their own say, "Wow, I feel great with this." Can I just come in? Like, could I come in like every week or two? Yeah, I've got one patient right now. She's the sweetest lady. She's 74 years old, so she's a Medicare patient. I've already told her what Medicare will and will not do with her, and I'm about to cut her free from that. So when she comes back in town from vacation, I told her we're gonna have that talk, because she said, I told her about this one patient of mine who's 83, and this patient of mine who's 83 comes in every 2 weeks. She's been coming every 2 weeks for years. I don't bill Medicare. She's a maintenance patient. She pays cash for this, and she just feels better with that. So I've already told this 74-year-old patient. She goes, well, that's going to be me. I want to come in, and I said, okay, well, you're gonna have to pay cash for that. She goes, that's okay. I need to come in every couple of weeks and do that. I said, okay, we'll do that. So she's been educated, and then if she wants to do that for the rest of her life, That is her prerogative, but I'm not going to make her do something and come up with some crazy treatment plan for that. Does that make sense?
Yeah, it makes a lot of sense. And I'm really glad you kind of laid that out, and laid out, in a way, it's our place in the medical umbrella. And our place is working with the neuromuscular skeletal dysfunctions. And like you said, having very clear goals of the outcomes that we want to achieve in terms of symptoms and function, and working towards those goals with the treatment program, and then seeing if we achieve those goals or not. And if we didn't, recalibrating, changing the treatment plan, maybe referring to somebody else, whatever it is, taking a lot of accountability and moving in a very specific direction. And yeah, you may have people who really want to be kind of on a wellness care program. I mean, who isn't going to function better if their joints are moving well, especially as we get older? So it makes sense. But, like you said, like that's not what you're selling. That's just an option that people have if they need it.
Right.
So I know people are going to want to learn more about you. They're going to want to kind of follow what you're doing. How can people get in touch with you? How can people learn more? Where can students find you?
So I have a website they can go to, which is www.gotdocumentation.com. So the name of my seminars is Got Documentation. So it's G like George, O, T like Tango, and then the word documentation.com. And I could be emailed at Dr. Gregg, and I've got 2 G's at the end of Gregg. So it's DRGREGG at gotdocumentation.com. Or they could go into any of these different Facebook groups that I'm in for chiropractors. I'm in a bunch of them. So just say the word documentation or tag me, and it's like my bat signal or something.
Perfect. And I'll put those links in the show notes as well. So that's really easily accessible for people who want to reach out to you, and learn more. So thanks, Dr. Gregg Friedman, for being on the show. Really appreciate it.
Thank you, Noah. Look forward to having joined us in the profession. Thanks for your time.
Definitely. So this has been a production of DC2B Revolution. If you enjoyed this video, please consider subscribing to the channel, liking the video, leave comments below. I think this is a really important conversation for us as aspiring chiropractors to understand, documentation and be able to document better. So thanks for watching.